Hello and welcome to the Lancet Pulse. I'm your host for today, Chloe Wilson, and we have a very slightly different format for the Lancet Pulse feed today because it is related to a piece of content that we've just published. And that piece of content is a health policy piece which discusses changing the name of polycystic ovarian syndrome to a name that better reflects the disease. For decades, PCOS has been criticised as quite a confusing or even misleading term, and many people who are diagnosed with the condition don't actually have any ovarian cyst. The name itself can very much overshadow the broader metabolic and hormonal features that shape patients' individual experiences. So I'm very excited to be joined by Terhi, Piltonen and Helena Teede as we discuss this major shift in how PCOS is named and hopefully understood. Supporters say that a name change better reflects the condition's links to things like insulin resistance, cardiovascular risk, and long-term metabolic health. But others question whether a new name change can address the gaps that there are in diagnosis, care, and public understanding. So let's get into what's behind the proposed change, as well as what it can mean for patients, clinicians, and research. Keep listening to hear more. So I'm absolutely delighted today to be joined by Helena Teede, who's a Professor of Women's Health and Endocrinologist. Would you like to introduce yourselves to our listeners?
Yes, so Professor Helena Teede, I'm an endocrinologist and academic from Australia, and I've had the privilege of working with patient groups and other groups around the world in this initiative over the last many, many years.
Thanks so much. And then we've also got Terhi Piltonen, who's a Professor in Obstetrics and Gynecology and Reproductive Endocrinology. Would you also like to say hello?
Hello. Yes, so my name is Terhi Piltonen. I'm a professor and in women's health and reproductive endocrinology specialist and been working with PCOS for many years. And now currently I'm the president of the International PCOS Society.
Brilliant. Thank you so much. So we're going to be talking about a new publication that you have just had released in the Lancet. Can you tell our listeners a bit more about that publication and the process behind what we're discussing on PCOS today?
So what we've done over the last 10 years is work incredibly closely in partnership with those who have lived experience with patients who have the condition. And it was their voice and their advocacy that really allowed us to partner and do this. What we did know is there's 170 million women of reproductive age globally with this condition, and many also postmenopause who are affected. We also know that there's significant delay in diagnosis, that there's dissatisfaction with care, the care is siloed, often focused on gynecology, because there's a perception this is an ovarian disorder. And that's in part because of the name. So we have a real problem with the misnomer of cysts. They are actually not abnormal cysts, and Terhi will explain that in more detail in a moment. But what we do know is this is an endocrine condition, and the science is very clear. It is an endocrine condition with metabolic, reproductive, psychological and dermatological implications. It's complex and it changes over the lifespan. And in that context, we knew this was an inaccurate name. We've gone on an incredibly robust journey, which is why this is published in the Lancet. And over that very rigorous process have come up with a new consensus name and reached 98% consensus in the end, that it is now called polyendocrine metabolic ovarian syndrome, or PMOS, moving forward. I'm just going to get Terhi now to touch on the really important problem of the fact that it was previously perceived as a cystic disorder of the ovaries.
Yes, yeah, absolutely. So, Helena, what you're referring to is that the previous name, polycystic ovary syndrome. I think the focus was very much on the ovary, as we know, and also the wording cyst. It's not really accurate. When I see the patients, in many cases, they've come to your office, and this is the experience of many other clinicians as well, that the women come to your office and say that, I think I need my cyst to be ultrasound, so and to examine, and they're very worried about their ovaries, and then you go over what is actually there. So they are not cysts; they are small antral follicles that are containing an oocyte. So these little small follicles, they are just kind of on the rest of their developmental stages, and I always explain that it's a very lush and lovely ovary. It's just very full of these cysts, and that we have women that have very few of them, but you actually have many of them, and this will carry your ovarian alive longer than for other women. So we have just published a paper that is really systematically, it has approach. We have examined 2,000 women and done an ultrasonography for all of them for their ovaries and assessed whether they have benign or pathological cysts in the ovaries. And that's not the case. They do not have any more cysts, like the cyst, what we mean here, but they do have more antral follicles, and this is what we already know. But now we have a publication there, and this also supports the name change, because the women should not be worried in that sense about their ovaries to get more ultrasounds, etc., examinations for the ovaries, because you don't need to look at the cyst or only monitor or control them.
Knowing, and we demonstrated this in research around the world, that there was very significant delay in diagnosis, high dissatisfaction with care. It was clear something needed to be done. And in fact, in 2012, at an NIH workshop that we participated in, there was a strong recommendation the name should be changed. And it was almost changed at that time, but there had been no patient engagement at all. And so it was felt that should now occur. There was also some disagreement around the world about whether it should change, but the biggest contentious issue was what it should change to. And so going on the journey, one of the things that was clear is that over the years there was a lack of leadership. Who had the right to lead this as a big initiative? How do we make sure that the patient voice was front and centre and it was in partnership with them genuinely across the journey? People faltered at the fact that we didn't actually have the final name. But when we came up with a process to agree on how we were going to get there was much more acceptance. And the fact that we needed an implementation strategy and an impact assessment. So basically what we've done here is bring an initiative along the journey that addressed all of those. And that's why we've finally been able to get over the line. So we have actually done some research that looked at why this matters for patients, clinicians, science and policy, what the mandate was for change. So in fact, with a PCOS Society and with our Centre of Research Excellence and with our patient groups, we undertook a process of surveying around 8,000 health professionals and women around the world and achieved a mandate to say, yes, we do need to change the name. And what's more, to show that most people perceive benefits would outweigh risks. And it was on the basis of that mandate, for the reasons we talked about, that we could then go on this journey to actually make the change.
So just as a summary, so the name of PCOS is changing to PMOS. And the reason for that is that the science around PCOS was inaccurate. That led to misunderstandings in the treatment of women and what they were asking for their clinicians and the understanding of the disease. And it's felt that PMOS much more accurately represents actually what's going on with the disease. So tell me a bit more about the process, though. You said it was a very big process and it included a lot of clinicians from various different parts of the world. It had a huge number of patient representatives. Was there anyone perhaps who wasn't included in the process that you would have liked to have been? Did it all go exactly as planned? Is there any follow-up as a next step to this being the first process? Or do you think this is the end of the discussion and this is the new name change?
The important part here was the process. It was transparent, global. Everybody we could reach was included. And it was not smooth, but it's not meant to be smooth. So it used implementation, it used really robust methods, very democratic. First of all, we had 3 core partners. So there was a patient organisation, AEPCOS, and also the Centre for Research Excellence from Australia, who was funding and leading the work with others. All the disciplines that were relevant were involved. We had patient organisations from every world region, and we had pretty robust governance. The 56 societies were really important because they covered all the different features of this condition and often areas that had not been particularly involved. But the process itself was really important. And in fact, it's unprecedented in a name change. We're pretty proud of the fact that it's an exemplar of patient co-leadership and co-design at every stage. And it used modified Delphi, nominal group technique, implementation science, and our patient group also brought a lot of expertise in marketing. And so all of that came into this. And so we took through that process. And perhaps do you want to just touch on that, Terhi?
Yeah, so in the beginning there was the governance of this the process and of course the funding that was acquired to start this process. And then, of course, then the very stringent, the Delphi process, which was global here, and really trying to underline that there were all these international societies were involved, and also the patient organizations, and there were representatives in the end for each of these organizations that were involved. And these about 90 people were then who represented the societies, all these 56 societies were invited into these workshops that we worked on several times when we narrowed down the options one by one. So we started with so Helena, are you going to talk about the process, how the name was eventually done? But in the end, so we narrowed down the options, and then with the last voting, we went through what are the final options, and then went back and looked at into different angles. And also, of course, when we have these are people that are having this condition, so really taking into account their opinion and also cultural aspects, because they will be now carrying this name. So that was really, really important, and I think that was one of the processes that I was most proud of along this road trip that we have done together. So after that, now when we have decided in the end what is the name, I think the true work happens. But maybe Helena, you can talk about the really the details. How did we end up with this name?
Yeah. So I think the first thing was that the principles that we all applied were voted on. So in the multiple surveys that came into those workshops, the most important thing was that it was all about better patient outcome, facilitating diagnosis awareness, making sure care was evidence-based, so taking that science into the name and into practice. That therefore scientific accuracy was the most important priority for women and also for health professionals. We had a commitment to avoid stigma. This is a condition that carries a great deal of stigma, especially in cultures where reproductive health is linked to a woman's individual worth. And there was a lot of things to consider here. Clarity of communication, cultural appropriateness, and feasibility of implementation were our 6 priorities and principles, and that was agreed. But then how are we going to approach this name change? And the options were, do we get a new accurate name? And so we start that journey. Do we do a generic name like diabetes or asthma, which has no stigma but doesn't help in terms of explaining? Or do we try and retain the P, the C, the O, and the S and come up with different words? And the really interesting thing was it fell out very clearly. Less than 50% wanted to retain the acronym. There was too much pain and stigma around that. Less than 50% wanted a generic option. So we were all focused on a consensus around a new accurate name.
And actually, there were lots of discussions on retaining the old name, because of course that aroused lots of feelings as well. People had invested in that old name, so in that sense, I think it was good to have a consensus and kind of a like a really transparent process of showing that it was not majority who wanted to keep the name, because people were really afraid that this would not change anything if you still keep the acronym. Though I think that was a very important point. Yeah.
And then the next thing we did was talk about which terms, and that this was not controversial initially. So endocrine is clear. The science, we're very, very clear there's an endocrine condition. There are multiple hormones that are affected here: androgens, insulin, neuroendocrine changes. That was very strongly supported, and there were both 2 terms, endocrine or polyendocrine, and either of them were equally supported by both groups across world regions. Metabolic, again, very clear. This condition has quite profound metabolic implications: insulin resistance, type 2 diabetes, diabetes in pregnancy, and cardiovascular disease. So again, that was not controversial. So the endocrine, polyendocrine, metabolic were there. The difficulty we came to was what reproductive term. So reproductive is probably the most inclusive, but the problem was it had real stigma. And there are parts of the world where a woman with a reproductive disorder can have some pretty profound life altering implications. And listening to that voice from around the world was really important. So we went through many of the different options, and I mean many different options across serial surveys and workshops. And in the end, the most favoured was ovarian. And the reason is it's not just ovary as a gland. It captures the follicles, the endocrine disturbance, the follicular disruption, all the hormone changes that occur because of the ovary. And the other options were really not fit for purpose. So we had endocrine, polyendocrine, metabolic, and ovarian, and we knew it was a syndrome. And so then we next went on the journey of how do we put those together. And we came up with a few combinations, but they had real implications, again, of stigma. And so in the end, what we came up with after some pretty solid marketing advice was to come up with polyendocrine metabolic ovarian syndrome, so PMOS. It's different to PCOS, but it's just a new chapter or an evolution of this condition based on scientific understanding. It's not a revolution, it's a next chapter. And so that name came out of that very rigorous global consensus process. And every single step was in consultation or in partnership with patients. In fact, they voted about 3-1. So there was more engagement from patients than there was from health professionals. And so in that context, we then came up with a name which reflects the genetics, it reflects the clinical features, it gets rid of the cysts, which are not there in terms of abnormal cysts, and it really sets the stage to completely reclassify this condition, and that's what's most important. We've proven from our guidelines that we've developed in 2018 and 2023 that there's a dramatic improvement in awareness in this condition, but we've proven that we've sort of hit a stalemate because at the moment, policy, research, funding, therefore evidence, therefore education and care is all about the ovary and the cysts that don't exist and not about the broader condition.
If I can just jump in and ask, I mean, it sounds like an amazing process that you've put together, and especially in a condition like this where there's so much stigma. I think the fact that you had such a collaborative process here and involved individuals who are affected by the disease is so important, and it could be a brilliant exemplar for other conditions, which, you know, it's not uncommon that there are many conditions that have a name which doesn't reflect current understanding of the disease. And I was just wondering, you know, did you have any examples of other diseases that had gone through a similar sort of process that you use as an example? Or if you could just tell us a bit more about that, kind of how you even got to the point of developing this amazing process that you came up with.
I think the most recent ones are the MASLs, you know, the non-alcoholic fatty liver disease that definitely, you know, deserve the name. And then also diabetes insipidus. And even in my own mother tongue, the diabetes insipidus is even worse, you know, for its translation. So I think these are the ones that really deserved a better name. And these are, but also in the gynecology, there is the premature ovarian failure that, you know, is now premature ovarian insufficiency because, you know, of course you do not want to fail. So I think, you know, these sort of aspects are very important to take into considerations as we just talked, that these are people who are carrying these conditions and they need to carry the name. So I fully agree that, you know, giving a name that it's easier for the women, for the patients who are affected, but also that if you can translate something about the disease so it makes it more easier to explain, it definitely underlines the need for name change in many occasions. But Helena, maybe you can tell, because this was a quite unique process.
It was. So I'm an implementation system scientist in my research, and yes, it's applied to women's health. But when you want to get a global consensus, you need a rigorous, transparent process with governance, and so that people can feel that they are always building on collective evidence. And what this does is take out the loud individual voices. That's the academics, the clinicians, but also occasionally the individual patients who don't necessarily represent the broader group. This process does that. Everyone has an individual vote along the journey. And so I have used this very rigorous implementation process in a whole range of areas. And so it was really a scale up of that. I don't think I've seen it used at this scale globally before, and it does take some pretty tough leadership. But it is fair to say that we learnt from some of the previous experiences that nothing has replicated the extent and the scale of this partnership, and that became important. There are already other name change initiatives that are using this method, so it will replicate the transparency in the process. And I think we would not have got here, one, without the patient co-leadership, and they will tell you hand on heart, they went on this journey together, but also without the rigorous process to be able to cut through individual opinions and move towards a trusted, reliable, credible outcome.
Yeah, I mean, I just think it's such a brilliant example of how important language in medicine is, and that the language that we're using to describe diseases, even, you know, beyond a disease name, the terminology that we use, like you said, avoiding words like failure, that we've been trying to do a lot more across medical journals as well. And that's why we have guidelines for using inclusive language, because it matters so much. And often I think it can get lost when you are busy in a clinic and you have lots of other things going on. But this is just such a great example of how a process can be put together and then hopefully change outcomes for patients. So I guess that leads me on to my next question is, if you were to look forward, say, I don't know, 2 to 5 years time, what would mark success for you of the name change? What are the hopes as a result of this process?
So perhaps if we can take one step back and say it would be irresponsible to just come up with a new name and not have a really robust implementation process, again, as an implementation scientist. So the good thing about this is it doesn't stop here. This is just the next chapter. So there is a very robust 3-year plan. So it will be PMOS, formerly PCOS, for the next 3 years. And in that timeline, there'll be some evolution together and learning as we go. But again, we're going to follow a very robust process. So coming out in the Lancet from credibility is really important. But we also have accompanying publications that will come out in other really prominent journals that will highlight the importance of this work. For example, in adolescent journals, in cardiovascular, in diabetes, in psychology, so all the features that have been ignored. We've got resources in about 20 different languages already that actually explain what we've just been through now, the why, the how, and the what. There's a global communication program, and those 56 societies will get a detailed pack of newsletter content and website content and what have you. We will work with the electronic health records to the SNOMED classification to change the terminology. Really importantly, we'll get this reclassified in a health policy context. For example, some governments have already started to move it out of gynecology ovary box into an endocrine broader with the manifestations across all those areas. And then that moves across to research funding priorities. But ultimately, then we'll change the ICD coding for the condition. And it's interesting what you require to go through that process. Looking at people who've previously changed names, nothing has touched the scale, rigor, transparency, and partnership that's been done here. And we're super proud of that. But it does mean that ICD process will not be hard. And then at the end of those 3 years, the next international guideline update in 2028 will be the end of the old name and the definitive landing of the new.
I think many people are worried that that this is going to happen like overnight, and I think that really underlying the fact that there is a 3-year transition period. It's a process, yeah.
Yeah, absolutely. So it's about more than just the name change. It's what then happens as a result afterwards. Because we talked a little bit about how the science and our understanding of PMOS has changed. But what is the current state of research in PMOS, and that how are we doing with current research, and then thinking about if we did change it to being recognized as a broader endocrine disorder, how do you see that then changing input into research in the disease?
So that's already happened with the NAFLD-MASLD transition. They've been able to get it into metabolic spaces more clearly. For example, in the US, it was always stuck in the box of only the Institute of Women's and Child's Health, and therefore wasn't funded outside that box, which is a very small funding pool for a very broad range of conditions. We're seeing already a trend towards recognition and funding in other boxes, but this should accelerate that. Likewise, many governments actually decide on research funding streams based on that classification we talked about before, which will now change. And it's not that it doesn't include reproductive health, because it does, and it should still be funded there, but it can't just be funded there. So we know it will build greater awareness of diabetes risk, of pregnancy complications, which are really quite profound as well, of cardiovascular risk, and of the psychological features. So actually getting recognition of the condition will allow us to advance the science. But perhaps if we flip it the other way, it's the science that really also drove the change. The genetics are endocrine and metabolic, hence it's a polyendocrine metabolic condition. The underlying pathophysiology is endocrine, metabolic, and reproductive. And then the features are endocrine, metabolic, dermatological, and psychological. So actually it just builds on the genetics, the pathophysiology, and the clinical features. And that's what we know from research currently.
And then I'm also hoping that I think with the name change, that we are able to also pull in researchers from other fields that probably have neglected. They have research in some areas, some very mechanisms or things that haven't been touched yet. So I'm hoping that the name change will actually bring more scientists and work on this really common syndrome, and in that way also broaden up the science field.
Are there any particular areas that you think have been quite understudied in relation to PMOS?
I think pregnancy is a big issue.
Yeah.
But to be honest, pretty much all of it. If you consider how many women have this condition and the fact that the quality of life impact is the same as diabetes, it's pretty horrific. But yet you get conditions that have important but far less prevalence, like rheumatoid arthritis and systemic lupus erythematosus, that have a funding ratio of 10 to 1 with this condition. So the bottom line is, we need to increase the relative funding in this condition. And then there are aspects of it, pretty much everything outside of infertility care, that the guidelines have demonstrated there needs to be gaps. And there was a really robust process to generate what is the next research gaps that women and health professionals want addressed. So that came out of the last guideline process, and that's actually published in Lancet eClinical Medicine. And then there was a James Lind Alliance process in the UK that again went through that with patients and health professionals. So we actually know what the research priorities should be. And now we're hoping this will increase awareness and funding to address them.
Yeah, absolutely.
Yeah, another area that I'm thinking, that aging, because now it has been considered with that ovarian story, it has been considered only to affect reproductive age women, and we know that this is a lifelong condition. So I think research beyond the reproductive years is really warranted in the future.
Yeah, and the patient's top priority in the James Lind Alliance, and indeed what came out of the guidelines, is models of care. At the moment, these women sit between, well, in fact, they often don't, but they probably need to sit between endocrinology, dermatology, cardiology. There's probably about 8 different specialties they could be involved in, which just tells us we need really, really upskilled primary care clinicians who can work with these women across their lifespan. It is 1 in 8. So it's really something we need to be much better at primary care, but then making sure all those other specialties can come in. And it's not like diabetes or indeed so many other conditions. You have endometriosis and other conditions, again, underserved, but you can go to specialist care for that. And in PMOS, there is almost no dedicated services. We've met and looked at almost all of them, and they tend to be infertility services or one particular area. So actually there are very few examples around the world of good models of care. So from the patient's point of view, their next priority is actually what is the best model of care to support them.
And I think we're going back, for example, that the most of the diagnoses that we got from PMOS previously they have risen from the infertility clinics, and thinking about that their goal to get the women pregnant. So as soon as the pregnancy occurs, after that, there is no continuum in their treatment. So they are very much left alone. And then considering also that many women do not consider even getting pregnant, or they do not wish to get children. So this doesn't really serve them, that that would be the only way how the diagnosis would kind of occur to them. So I do agree with Helena that with the primary care, and now when we have the data also on the ovary, that they do not have any more pathological findings in the ovary. So kind of a unnecessary ultrasound examination, which are very expensive, altogether, at least in the societies where you do not, the care is kind of grounded in a primary care, and then after that you can only refer to the specialized care, which is more expensive, and there is limited resources. So just by having these data from the ovaries, and also the how to diagnose and how to make that diagnostic path even more burdensome for the specialized care, and have the care in the primary care, and then with the specialized care, some of these aspects that do need some consultations or visits, but that somebody would really take over their overall health, coordinating their
and the other thing that
health.
we're working on extensively with patient groups is actually shared care. So there's been a lot of shared decision aids that have been developed over time. Sadly, Only one ever in women's health, because apparently women don't need to be involved in shared care. So we are changing that. And by the time we finish next year, there will probably be about another 15, so 16 instead of one, shared decision aids that actually empower women to work with the health professionals and personalise their care. And that's really going to be the future of this condition, not the least of which they've got so many people to coordinate, but actually based on their values, what's important to them, their experience at the different life stages. Because when they're an adolescent, their problems in health are totally different to when they're in a more reproductive age to when they're in menopause. And between women, they're different. And between ethnic groups, they're different. This is just a heterogeneous condition. So how do we empower them, provide them with care, but help them on their journey about what's important to them? And the name is not everything. It's the next chapter. But without it, we were stuck and we couldn't change that policy research, which means we don't get evidence, we don't get guidelines, we don't get education, and therefore we don't get care. And probably one of the most important things is if one more person says just educate the doctors and it's all the doctor's fault, that never works, because it's not just educating the doctors. It's that whole cascade of policy, research, evidence, education that we're addressing together as a global consortium. And the name was one next vital step in that.
And is there a plan in place for thinking about how we can better primary care services to better serve women who have PMOS? Because I don't know if there's any sort of robust data on referral numbers, but I would imagine, so I used to work in primary care, there's a lot of misunderstanding probably from primary care physicians about who needs referral. And it's, it might be that it's actually the condition, as you said, is only diagnosed if somebody's wanting to get pregnant, so for reason for infertility, and then might not appreciate if a referral is needed if a woman wasn't looking to get pregnant. So I was just wondering what your thoughts are on, because I agree with you, education is going to be a big part of it, but it's not the whole part of it. But how do you put those plans in place to help primary care to better serve those women? Because it is a big challenge, because obviously primary care physicians, their demand is huge, resources are often quite limited, so it can be difficult. And I think you're right, it's probably more to do with a shared model of care.
I mean, one of the things we're working on collectively is around a best practice framework. So, for example, for fracture capture, so we know that fractures in endocrinology almost never get the osteoporosis medication they need after they've had a fracture, though they're really high risk. So the best practice model of care didn't say you have to do it this way. It says these are the elements you really must have, and adapt it to your environment and collect the data and evaluate it. So that, that underpins over 500 fracture capture services around the world. So we are currently co-designing the best practice framework for PCOS, for PMOS models of care with patients. And that will rely a lot more on patient empowerment and on giving them digital and other tools so that they can co-lead and share their care with their clinicians. But the pathways in a best practice framework have triggers around when to refer and who to refer. And that's all in the shared decision aid. But I think the answer comes back to what we said before: policy framing, research, and research includes models of care and how to support GPs and primary care through to, digital all the way through. And then education. I had 1 hour of education, I don't know about you, Terhi, in my 6-year medical degree on this condition.
Yeah.
Did you get
much more? Well, I think that was it,
So undergraduate, postgraduate, but it's not just education. It's actually much more than that. It's making it easier for those who are affected and those who care for them to do it better.
And I think now the modern technology, as you said, prompts or AI that is able to, built-in programs that could, because I think in many cases it's also the problem that we don't pick it up. So, how to make people to pick it up from the symptoms that should be asked, and how to have that red flag that, this is PMOS, you should look at this and that, and, this is the framework around it. But how to get that first, alert, I think we do have ways to facilitate that as well.
Absolutely. And then I guess just my final question is just thinking about the implications, not just on primary care and hospital physicians. I mean, how Do you think that this will change things for international guidelines and other sorts of tools that we use? You mentioned ICD already, but it would just be great to think about the wider network outside of just clinicians as well.
Again, I think that's all in the plan. So with the APCS Society and all the other societies and the patient groups, it'll go right through from journals. For example, there's a letter to go to every editor in any journal that's really published in this area talking about the name change. In fact, the research nomenclature is the easiest to change, because once the search engines know that if you look for PMOS, you get PCOS, and if you start with PCOS, you get PMOS. So those sort of digital systems are relatively easy. But the plan here learns from all the previous name changes, good, bad, and ugly, the ones that failed and the ones that succeeded, and builds on the incredible partnerships that are already there and the goodwill to be able to do this. So I'm not concerned about the next steps, to be honest. It's a pretty clear pathway, and it's a really robust collaboration to get there. So I think, again, we hope this is going to be an exemplar of how to do it effectively.
It's brilliant. I think the whole process is a great exemplar for how to involve a multidisciplinary and diverse set of people in making a change like this, which has big implications for how PCOS, now PMOS, is viewed across various different aspects of medicine, and actually in research funding, and then how it is implemented in policy. The Lancet will be using PMOS, and we hope all of the other journals will follow. And as you said, it's great that we now have all of these digital tools so that, as part of your search strategy, you can make sure that you've got PCOS to find older papers as well as PMOS. Was there anything that you wanted to add for our listeners, or a final note that you wanted us to end on?
So I think, now with this wonderful process and all these people's, engagement, I think we need still that, people wouldn't drop it here. And I don't assume that would happen, but I think this will need everybody to be involved. I think people are included in this process, and they are very warmly welcomed, and everybody's help is needed to really disseminate this and make the change. So I think that's my final word.
Helena? Yeah, I think the most important thing we now need to do along this journey is also prevent misinformation. The amount of misinformation out there on social media through influencers who have a vested interest, who are selling the latest supplement or the latest diet, is just distressing. I follow most of the Facebook pages in this space, and it is really distressing. So one of the things that we need to do in this journey is also make sure we get accurate evidence-based information. And the Ask PMOS app, there's also a version that says Ask PCOS, is used in 195 countries, is completely evidence-based, is co-designed, and we'd like to make sure people use those resources and go to the APCOS website, search up PMOS, and you'll get to the right information. That's a really important message for health professionals. There's a whole range of resources for them. And then for patients and consumers, there's a massive amount of resource there. So I think just making sure we avoid that pitfall of people who have a personal vested interest. For example, Terhi and I have both had to work with groups who didn't want to change the name because they were worried about having to pay to rebrand away from PCOS to PMOS, and yet not necessarily seeing the depth of poor experience that those in the community were really having. So accurate information on the journey and partnership and sharing. So if you could put the Ask PMOS app in there, that would be wonderful.
Yes, thank you so much to you both for joining me on this podcast. It's been really informative, and I think, as I've said several times, I think it's a great example of having a transparent and robust process that involves people with lived experience that, really hopefully will set a trend for other diseases that are considering a name change, as well as having a plan, because while, as we've said, the name change is really important, it's, a lot of it is going to be about what happens afterwards. So although that we've said how important language is, it's about the follow-up on that afterwards, and actually changing those attitudes and actually improving outcomes for women who've been affected by PMOS. So thank you so much to you both, and we hope that you've enjoyed listening. So I hope you have enjoyed this episode of the Lancet Pulse, and that you will go away and take a look at that health policy piece in more detail. I think from the discussion, it's clear that a name change can't change attitudes and understanding alone, but that it's a very big part of the solutions, which is why it's so important that along with the name change, there has been this well thought out implementation plan. Still think a key area to address is going to be in primary care, as that is where the majority of people who have PCOS are having their symptoms recognised and referrals made. But it's of course a huge challenge because primary care systems globally are struggling under the current demand, which is far exceeding the resources which is devoted to primary care. And I think a big part of making sure that the implementation plan works is going to be strengthening primary care, as well as strengthening the links between secondary and tertiary care, because things like delays in diagnosis and misunderstanding are happening across all levels of care, not just in a primary care setting. But I do think if adequate resources, training and strengthening those links are really well thought about with strategies put in place, then this will be more than just a name change and, will hopefully make a big difference to the lives of people who are affected by PMOS. So once again, I hope you've enjoyed listening to this podcast and we hope you will join us again next month.
Thanks for listening to the Lancet Pulse. If you enjoyed this show, leave a rating or a review on your favorite platform and subscribe to stay updated on our latest episode. The editorial team includes Chloe Wilson, Ben Abbott, Matthew Gilbert, and Jonathan Pimm. This show is part of the Lancet Group podcast offering and it's produced by Matteo Simonetti. Thank you for being with us.